Drugs and Diving by Dr. Frans Cronje. One of the features that distinguishes man from animals is our desire to take medication. Beyond the age of 18, nearly all humans take some form of medication, nutritional supplement or mood enhancer. If you dare to disagree with me, consider your next hot beverage. So now the question arises, how does all this affect Homo aquaticus? What do we know about medication and diving? Unfortunately, very little. It's easy to speculate on ways in which medication may affect us in diving, but most of these suppositions are not founded on fact. They remain best guesses, leaving recommendations on drugs and diving more to one of argument than evidence. It's certainly known that drugs can have unpredictable effects, and there's much about the diving environment that could make this a possibility and indeed a hazardous one. To date, the only concerted effort to address the interactions of drugs in the hyperbaric environment has been the 21st workshop of the Undersea and Hyperbaric Medical Society in 1979, where the collective knowledge and experience of 9 participants and 8 observers rendered the only real reference on the topic since the beginning of diving. Even this work had to rely largely on anecdotal information to provide guidance on the use of medication in high-pressure environments. Independently, the U.S. Navy has tested a limited number of drugs, for instance those used for decongestion and seasickness, and has made several recommendations, but there's still no simple answer. This is what they have to say in the latest version of the U.S. Navy Diving Manual. There are no hard and fast rules for deciding when a medication would preclude a diver from diving. In general, topical medications, antibiotics, birth control medication, and decongestants that do not cause drowsiness would not restrict diving. Diving medical personnel should be consulted to determine if any other drug would preclude diving. This is anything but clear. One excellent, albeit perhaps a less obvious resource, is the Aerospace Medical Association and its journal, because many drugs have been evaluated in the context of aviation safety, and many of the same principles apply to diving. But there are no simple, hard and fast rules, and there's no comprehensive or foolproof list of drugs in diving. So, my objective with this presentation is really twofold. Firstly, to give you some of the general guidelines that can be applied to any medication or condition, and secondly, some specific information about common medication used in diving and in divers. Let's start with some general guidelines then. First of all, there are 3 core components to consider. There's the medication, there's disease, in other words, what it's taken for, but also the underlying health of the diver, and then of course there's the diving and diving environment, and each of these may interact with the other. For instance, the drug may affect diving fitness, and diving may affect the drug effectiveness as well as drug side effects. Then there's the interaction between the drug and the disease, and that is made up of effects and side effects also. And lastly, there's the diving-disease interaction. In other words, does the disease impact on diving, and would diving impact on the disease? Looking at each of these in turn and their interactions, we arrive at a final conclusion whether or not diving would be appropriate. And we can reduce this essentially to 7 questions. First of all, what about the drug on its own? Is the drug intrinsically safe or unsafe? Secondly, what about the disease or disorder? Is that an intrinsically acceptable or unacceptable problem? Thirdly, the type of diving that the person's undertaking. Does the type of diving, for instance, a very strenuous form of commercial diving, make allowance for the variables that we need to consider? And then we've got the potential interactions, the drug and disease, the drug and diving and the disease. And lastly, the overall diving safety consideration. By asking these 7 questions, most of the issues surrounding medication and diving can be answered at least with a greater level of rationale and scientific principle. So with that framework in mind, let's start looking at the drugs. What are the so-called bad drugs? In other words, what are those forms of medication that would be considered intrinsically harmful In other words, it doesn't matter why you're taking them, the drug itself is a problem. And those are the drugs that would typically affect alertness or consciousness, the ability to think, plan, and to make decisions, and of course your capacity for exercise and enduring the rigors of diving. With this in mind, psychotropic agents, in other words those that would affect the brain for mental health or neurological problems, sedating or sedative medication, and antiadrenergics, of which beta blockers that essentially put a brake on the heart's ability to pump as well as heart rate would be potentially hazardous in and of themselves. What about the bad diseases? Well, with bad diseases, we're really referring to those diseases, again, that in and of themselves, irrespective of the medication and even the type of diving that's considered, would be considered incompatible with diving. And, as before, it would be those diseases in which alertness or consciousness cannot be guaranteed reasonably, those that would affect a person's ability to exercise up to a certain standard and, of course, have general performance compatible with diving, as well as pressure equalization. So, irrespective of whether the person is or isn't taking a medication, if they aren't alert, have basic consciousness, ability to exercise, and able to perform underwater, as well as equalize the airspaces, it doesn't matter what else is wrong, they have a disease that contraindicates diving. And here we're looking at psychiatric and neurological problems, heart problems, lung problems, ear, nose and throat problems, musculoskeletal problems, although with disabled diving there are certain provisions with additional buddies that may be considered so that these could be overcome, metabolic diseases where people could have dramatic falls in blood sugar, and acute diseases, in other words, risks for sudden incapacitation underwater that is unpredictable. These make up the so-called bad diseases. And then there are certain dives that also may be intrinsically dangerous. And I've used a mnemonic with ease just to make it a little bit more memorable. So they are the sort of dives that involve extremes of exercise and exertion, exposure to extremes of heat or cold. They may be elaborate in the form of a lot of technical or heavy equipment, and there may be extremes in terms of depth, duration, decompression stops, or the distance that needs to be traveled. With this in mind, one could consider, for instance, decompression stop diving or cave and ice diving, trimix or deep air diving, diving in strong currents or high seas, shore entries, and tough boat launches. These dives may be to some extent intrinsically hazardous, but when one considers them in the light of an underlying medical problem or the use of medication, these may be variables that the person can actually control. Now, as a recreational diver, it's relatively easy to do this. As a commercial diver, the option to simply choose not to dive becomes a very, very difficult one because of the employment, employer expectations, and just the nature of the job. So, for recreational divers, there's somewhat more leniency on some of these issues than there would be for commercial divers. So now let's turn to the specific drugs. And the ones I've selected are the ones that are most likely to be used in a diving setting. And those would be some decongestants, motion sickness drugs, antimalarials, antibiotics, antidiarrheals, and antihypertensives or anti-blood pressure medication. To make it simple, I've used some symbols to basically summarize some of the core concepts. So the smiley stands for the effectiveness of the agent. In other words, does it actually work? The bomb is for the side effects that could potentially impair a diver or cause diving safety issues. The skull and crossbones relates to safety and special precautions related to the drug. And finally, the drop represents the dosage. So, let's start with this drug, one that's commonly been used in diving, pseudoephedrine or Sudafed. Previously, this was an over-the-counter drug, but recently, due to drug issues, this drug has become controlled, and therefore pure Sudafed, that is 60 milligram tablets of only pseudoephedrine, are no longer available without a prescription. Its indication is to improve Eustachian tube function and deal or prevent with middle ear barotrauma or equalizing issues. And indeed, it's effective. It reduces diving-related ear blockage problems from 34 to 8%, and in air travel, it causes a 52% reduction in middle ear barotrauma. The dilemma is it's related to adrenaline and therefore can cause anxiety, heart palpitations, and because it affects the prostate in those that have prostate enlargement or urine problems, it can actually lead to bladder obstruction. For the most part, it is safe with minimal side effects on the proviso that individuals never take this drug prior to diving for the first time. In other words, it's not the time to discover whether you do or don't have side effects underwater. It should first be used on land and verified that it doesn't cause untoward effects. One should also note the cardiac, blood vessel, and prostate-related problems. The dosage, 60 milligrams, 30 minutes prior to diving, is the recommended application. And the reason for this is that the drug lasts approximately 4 hours, and you wouldn't want to have a reverse block because it was taken too soon prior to diving. In my application, this drug is really only indicated for people who can equalize but possibly have some difficulty with one ear relative to the other, or suffer from so-called alternobaric vertigo. In other words, when they return to the surface, the one ear tends to retain a bit more gas and they get mild spells of dizziness. We don't like divers taking it deeper than 24 meters, and we also don't like it with oxygen-enriched nitrox or high oxygen percentage and partial pressure mixtures. The next drug is the topical equivalent, which is called oxymetazoline and is known by a variety of names, including Drixine, Afrin, and Iliadin. Unfortunately, most of the studies have shown that it really isn't much better than a so-called placebo. In other words, no better than just rinsing the nose. Also, because it's related to adrenaline, and particularly if people overuse and apply too many drops, it can cause the same anxiety and palpitations that you might get with Sudafed. For the most part, it's safe with minimal side effects, and again, like with Sudafed, one needs to consider the cardiac, vascular, and prostate issues. Theoretically, it can be applied underwater, although that presents a number of theoretical problems and, of course, the potential for choking, etc. But divers that have suffered reverse blocks related to the sinuses have used that with some success. The place where I would consider using it, again, is with sinus-related problems specifically, and also people that suffer with routine congestion. Some people just have sensitive noses. They even find that the nose decongests, or rather the nose congests even with weather changes, and these individuals seem to benefit from the use of oxymetazoline. 2 sprays or 3 drops per nostril 30 minutes prior to diving is the recommended dose. So now let's switch to motion sickness, looking at the first drug, which is relatively mild, called cinnarizine or Stugeron. Stugeron is effective for mild forms or low-grade forms of motion sickness. It's usually taken in a dose of 15 to 30 milligrams, and it's extremely effective when combined with domperidone or motilium and potentially ginger. At 15 to 30 milligrams, it has minimal side effects, although it can cause sleepiness and reduced performance, particularly when the doses are increased. It's pretty safe at the 15 to 30 milligrams level, immediately prior to boarding a diving vessel, and then 8 hourly thereafter. Antihistamines, and particularly dimenhydramine, also known as Dramamine, is effective for more moderate forms and even up to severe forms of motion sickness. The tablets are usually 50 milligrams, and it is very sedating. There's a chewable form that's somewhat less sedating, and it would only be considered safe for relatively shallow dives, and also if it has been used previously without undue side effects. Clearly, it has the potential to interfere with cognitive performance underwater, and it would interact with nitrogen narcosis. The dosage is 25 to 50 milligrams every 4 hours. Scopolamine is a transdermal anti-motion sickness agent. In other words, it's a patch. And this is very effective. It works within 6 hours and it lasts for 3 days. The dilemma is that it can cause widening of the pupils with blurred vision. It can interfere with mental function, including memory, psychomotor, perception, and coordination issues, and it leads to a significantly dry mouth. The US Navy recommends it with some very important precautions. Firstly, the hands should be washed immediately after application. The reason for this is that it's possible to inadvertently rub the eyes and transfer some of the medication, which would result in a dilated pupil. There should be at least 24 hours after application to observe for side effects, and then diving should be limited to no more than 30 meters or 4 atmospheres or its equivalent. The patch should be checked after each dive to make sure that it's still in its place, and it can be replaced after 3 days. And the recommendation is to alternate the sides. The trial of 24 hours again is very important, and as we mentioned, every 3 days it needs to be replaced. Then, phenytoin, an interesting anti-motion sickness drug. Phenytoin is actually an anti-epilepsy medication. However, based on aerospace research, it appears to be extremely effective for severe motion sickness. At the prescribed dose, which we'll give you in a moment, it's actually been approved by NASA for astronauts. At higher doses, it can cause slurred speech and incoordination, but it's safe for the typical recreational diver profile. One should be aware of cardiac conduction disturbances, but these individuals would typically not be divers. There are also many potential drug interactions to be aware of, and this should be prescribed by a physician who's knowledgeable about them. The typical dosage is 5 milligrams for every kilogram of body weight in either a single or in a split dose morning and evening. For the most part, it can be taken for up to 14 days, either starting the evening before travel or diving, certainly not immediately prior to diving. The next drug, promethazine, is actually best known as an anti-allergic or even a psychiatric medication because it's related to the so-called phenothiazines. But because it has acetylcholine as well as dopamine-related effects, it's the ideal antiemetic or anti-motion sickness agent. The only downside is it is severely sedating. However, one of the benefits of this drug is that the sedating effects actually taper off prior to the diminishment of the anti-motion sickness effects, which means if you take it the night before diving, it will still protect you against motion sickness even though the sedating effects have terminated. So, in those situations, it could be considered. And of course, if a person has debilitating motion sickness, it might be appropriate as an intramuscular medication for the treatment. Of course, in that case, diving would be contraindicated. As a prophylactic, in other words, to prevent motion sickness, 25 milligram tablets should be taken the night before. Now let's switch to antimalarials. There are essentially 3 antimalarials that may be taken in Africa and most parts of the world in preventing malaria. We're going to start with the one that we least recommend, which is mefloquine or Lariam. Although it is effective against chloroquine-resistant malaria, it has a wide range of side effects, and the side effects may last up to 4 weeks even after a single weekly tablet. The side effects include dizziness, vomiting, fainting, pins and needles, and muscle pain, and in fact may actually look like decompression illness. And we've had a number of cases in which the diagnosis was actually unclear and ultimately could have been either. The psychiatric disturbances and personality changes make it an additional concern, and it's not recommended for either diving or pilots. But there is a potential exception I need to mention. And that is an individual who is already on Lariam and now wants to take up diving. If they have taken it and it's about 48 hours after the dosage, well, in the absence of side effects, it's probably not unreasonable for those individuals to dive. But we'd prefer divers not to take it. There are potential interactions with cardiac and epilepsy medication that probably wouldn't be relevant for divers, and the dosage is 250 milligrams per week until at least 4 weeks after the exposure. Atovaquone and proguanil, sold either as Malarone or Malanil in the United States or Europe, is at the moment the safest and most effective antimalarial. Unfortunately, it is also the most expensive. It is very effective against chloroquine-resistant malaria, and it is in fact recommended for people who are so-called unselected. In other words, where their medical history or disease history is unknown. It is also used for AIDS-related pneumonia. The only important side effect to mention is that there may be loss of appetite, diarrhea, nausea and vomiting, and in the setting of diving, we've noticed that some individuals seem to be more susceptible to motion sickness when taking Malarone or Malinol. There is the potential side effect of dizziness and insomnia, but this rarely interferes with diving. So it appears safe for pilots and divers. The gastrointestinal side effects predominate and motion sickness may be relevant, and the dosage is again 250 milligrams daily until only 7 days post the exposure to the malaria area. The reason for this is that it actually kills the parasite rather than just stunning it and leaving it for the immune system to mop up. Doxycycline is not only an anti-malarial, but it's also a commonly used antibiotic. So, in addition to malaria, it may be used for skin infections and certain tick-borne illnesses, as well as genitourinary infections or bladder infections. It can cause loss of appetite, heartburn, nausea, and so-called aphthous ulcers, which are lesions in the mouth that are quite painful. It also causes sun sensitivity, and individuals who use it should take precautions with sun protection factor 30 or higher. It's safe after 24 hours, verified with no side effects, and as mentioned, a high sun protection factor sunscreen should be worn. It's wise to avoid high calcium-containing compounds or solutions or drinks, for instance milk, and it may interact with oral contraceptives. In women, it may precipitate vaginal thrush, and this is something that may need additional or follow-up treatment. And there is a tip to take it early in the evenings after a meal to avoid some of the side effects, including heartburn. The dosage is 100 milligrams per day, and in the case of malaria, it would be taken for up to 4 weeks after leaving the malaria area. Ciprofloxacin is another antibiotic that's relevant, known as Ciprobay or Cipro. It's useful because it covers so-called gram-negative organisms. In other words, it may be helpful for certain gastrointestinal, genitourinary, or even certain head, ear, nose, and throat infections. It is particularly useful for so-called Pseudomonas infections, although it's unlikely that this would be relevant to divers, with the exception of certain forms of external ear or swimmer's ear infections, and this would probably be its primary indication. Of course, if that is the indication, diving would be contraindicated. As far as drugs go, its side effect profile is relatively benign. It can cause nausea and vomiting, can precipitate diarrhea, rash, restlessness, or dizziness, but for the most part it's safe with no side effects as long as the underlying condition is not the problem. The dosage varies between 250 and 500 milligrams twice a day. Loperamide or Imodium is the only antidiarrheal I'll mention here. It's related to morphine, although it's not narcotic, and it essentially causes the gastrointestinal system to shut down by a so-called spastic paralysis. It has various gastrointestinal effects, of course, and it could have mild central nervous system effects if it's taken at extreme doses. It may cause a rash, like most of the morphine drugs could do, and the more important thing is that it could reduce bacterial clearance. In other words, if someone has a form of diarrhea in which bacteria could invade the intestinal lining, then paralyzing the intestine could actually lead to an invasive disease. So if one has dysentery, which means that there's blood in the stool, or an existing invasive disease, Imodium is contraindicated. From a diving point of view, the greater concern is really the risk for decompression sickness that comes with dehydration. And dehydration, of course, is a result of diarrhea. So that is the more pressing concern as far as diving is concerned. But if the diarrhea is mild and there are no side effects, then diving up to 30 meters should be reasonable. The dosage is typically 2 tablets or 2 capsules immediately, and then 1 after each loose stool, up to a maximum of 6 tablets per 24 hours. And now the antihypertensives. Unfortunately, elevated blood pressure is extremely common, particularly in individuals above the age of 35, and so it's not uncommon that divers around 35 or 40 will be taking antihypertensives. If they do, the so-called ACE inhibitors or angiotensin receptor blockers, ARBs, are the drugs of choice. They can cause cough, particularly the ACE inhibitors, but this should typically be known by the time a person comes to diving with their medication. It can also cause ankle swelling, rash, or in rare cases bleeding, and for the most part this is the preferred drug for divers and for athletes and is generally safe with minimal side effects. Cough could be relevant in diving in terms of breath holding or because it might be confused with mild forms of asthma. There are potential interactions to be aware of, and there may be disturbances in blood electrolytes, although these are of very little practical concern. The dosage varies with medication, but most people who are on these medications will be on them or have been on them for a while. Of greater concern are the so-called beta blockers. The beta blockers essentially impede the effect that adrenaline has on the cardiovascular system, but it also has some effects on the lungs as well as the endocrine system. In other words, it is an effective anti-high blood pressure medication, but it slows the heart and the strength of the heartbeat. If people take this drug, it may affect their ability to exercise, and therefore, in general, they're contraindicated. But if people do take them, the preference is for them to take the so-called selective beta blockers. In other words, those that work primarily on heart rate and not so much on heart contraction or the other systemic effects. The non-selective beta blockers, of which propranolol or Inderol is perhaps the best known, may cause a variety of lung, glucose and blood vessel problems and are not indicated. So, if someone is on these agents, they should be able to prove that they're able to exercise without impairment and that their lungs aren't affected. The dose will vary, and of course, that would be something that a physician would need to sort out. Of course, prescription drugs and over-the-counter drugs are not the only ones to consider. There are recreational and illegal drugs that may be relevant to divers as much as the others, and unfortunately, they're very common. Now, tobacco, particularly if smoking occurs within 2 to 4 hours prior to diving, seems to increase the chances of a lung overpressure injury by a factor of 9. Cannabis has well described impairment or impairing effects on the psychomotor and cognitive skill set. Alcohol not only leads to drunkenness and interaction with nitrogen narcosis, but may lead to dehydration, even the following day, as well as an increase in the chances of developing decompression illness. And then there's cocaine. Now, cocaine not only has the chance of causing psychiatric side effects, but in fact it also may cause cardiac dysrhythmias and sudden death. So all of these should be avoided when diving. So, to summarize, diving is an energetic and adventurous activity that requires wakefulness, wits, wisdom, and some work. Medical conditions or their treatment may interfere with these prerequisites and therefore affect diving safety. If these risks are not understood, the results can be catastrophic. The lesson is, quit while you're ahead. Beware of drugs and diving, and of course, if you need more information, consult your diving doctor or call Dan.